So again, this session is recorded. If you want to be with camera, feel free to do so. If not, it's also okay. Okay. Deep, what do you say we start?
Let's go.
Let's start. We have Tali here too. This session is recorded. Hey, Tali. This session is recorded. Tali, I know. So very happy to have her here. So just a quick thing. This is a webinar that we're hosting about ketamine as a medicine. We want to talk about myths. We want to understand the risks and benefit and really kind of explain everything that we know. We're going to do, we have me as an expert and Dr. Deep. Both of us will kind of talk about all kind of questions that we got from other people before that, and also all kind of topic that we think will be interesting. So I will give a quick intro. We won't do a longer one, and then I'll move it to Dr. Deep and he can talk. So I'm a D. I have a PhD in clinical psychology. I've been working as a psychologist, well-being expert, and entrepreneur in the past 15 plus years. I also have a certificate in psychedelic-assisted therapy, and I've been working with ketamine-assisted therapy with individual and retreat settings, with Deep as well here. And I've been researching the field in the past, I want to say 7 years, since I actually sent a traditional therapy client to ketamine treatment and saw the benefits of it. And I have a ketamine clinic along with traditional therapy clinic here in Los Gatos, California. Actually not here because maybe people are not from California. I'm assuming everyone's from California because it's just the way I live my life. But and I will give the stage to Dr. Deep, then he can tell a little bit about himself and then we can continue.
Thank you so much, Ali. That was, I have to follow that intro. That's a tough one to do. Listen, it's amazing working with Ali. It's amazing working with ketamine, and we are on to a big psychedelic journey. Just in life in general, the journey what matters, not the destination. I did my med school in India. I did my residency and fellowship at USC. I'm the founder and CEO of Point Ketamine, which is a clinical ketamine format here in Los Angeles and up in the Bay Area. We do clinical, we do retreats, we do spiritual settings, we do different combinations of clinical and non-clinical around the ketamine and psychedelic world. It doesn't have to be ketamine only. But amongst all of it, the drug itself does amazing work. The psychedelics are a piece of it, and there are many more coming down the tree. But there's a big change from big pharma, big drugs, or traditional medicine to spiritual and psychedelic medicine, just to give you a format, which is really a wide range of stuff to do. Hopefully we can cover all of it in this hour. If not, we'll do another one to cover the rest of it. Hopefully we can get to everybody's questions.
Thank you, Deep. That was actually awesome. So what we want to do today, following what Deep just said, is we want to kind of introduce ketamine, discuss myth, benefit, risk, what are regulatory status and all, some research around that. We won't focus only on that, and then leave room for questions we already received and questions that will come from the audience. First of all, we want to say what ketamine is and how also it differs from other psychedelic medicines in the field. So ketamine is a legal anesthetic that in the past decade is also been discovered that in lower dosage it's used for treating a variety of conditions. Treatment-resistant depression was the beginning of that research, and there's an abundance of research around that, but also anxiety, PTSD, chronic pain. They discovered that it does behave as a fast-acting antidepressant medicine and can immediately improve symptoms within hours after administering it. The neurological kind of aspect of it is that it strengthens neurons connection that are weakened during depression. It increased neuroplasticity and also enhanced learning pathways. What it does is it blocks receptor that is named NMDA, which is also linked to glutamate, and makes the glutamate kind of enhance in the brain, and it plays a key role in the stuff that we talked about, which is brain reward and learning pathways. Lots of study in treatment-resistant depression, like I said, and how ketamine mechanism work, and there are great results. Also, recent studies in the past few years by Yale actually was an interesting study about teens abusing ketamine. This session will mostly be on talking about adult using ketamine, but there's a lot of ketamine research that is going on teens and how it improves anxiety, both social and professional, and other areas of life. Also, a lot of research about PTSD that is going on in OCD and how it improves trauma-related symptoms and also substance use. And we can talk about specific substance later, but it also known as reducing craving for substance use disorder. If we compare it to other psychedelics, which is if we talk about MDMA or LSD, DMT, psilocybin, it really invokes different kind of experience, because ketamine is more of an inhibitor versus other psychedelic medicine. So the subjective experience is different. Ketamine is known to have a more gentle experience. It's also a short-lived experience, which means it's 2 hours versus much longer experiences for other psychedelics. But it is a dissociative drug, and it has an outside of body experience, an ego dissolve, which we can talk a little bit about later, a kind of detachment from the body, and a floating experiences. But it's very subjective. It impacts different people in a different way. Also depends on dosage and the method of administration. So that is part of the difference. Some people would say that it's an easy entering and accepting the alter consciousness, ketamine versus other psychedelic medicines. So that is also, I can see there is a question. I will try to answer it afterwards. Or unfortunately, let me see. Okay, it is recorded, so no worries about that. Ask questions. I'll try to look. I see the chat, so I can look at it. Any questions regarding that, you can put in the chat and we can answer. But that was kind of the intro. Also want to talk about how ketamine-assisted therapy differ from traditional therapy, which is what we know, which is CBT, which is psychodynamic, client-focused therapy, and all other modes of therapy. There are all kinds of differences. Obviously, the mechanism, right? So the intervention that is more traditional is changing thought patterns and behavior over time, right? So there is a variety of methods to do that, variety of theory, kind of change cognition, emotions over time, and brain chemistry is changing over time as well from traditional therapy, not always, but it takes a longer time, right? So ketamine works directly on the brain, enhance neuroplasticity immediately. The impact on mood and cognition are immediate. So the mechanism is different. The speed, I think it's something that is clear, that traditional therapy can take weeks, months, much longer turns, and ketamine has a more rapid onset and can produce immediate symptoms relief due to the nature of the medicine. A combination of both is ideal, of course, but ketamine has a fast therapeutic response due to the nature of medicine. Duration and effect, it's also part of the myth, but we can talk about that later. But traditional therapy can produce longer effect on changes and on results. And ketamine is a shorter duration, but again, it really depends on whether you combine it with therapy or with other modes of treatment, and how you approach ketamine treatment. Do you get some boosters, or do you approach it as a longitudinal process? It's different for everyone, but some people, would have a lasting effect after using ketamine as well. Target conditions, so traditional therapy can have a broad range of mental condition. And ketamine has been heavily researched for treatment-resistant depression, and now is being researched for PTSD and anxiety and chronic pain. but not for all the condition. Like we will talk later about the condition that we are not recommended to use ketamine, like psychotic disorders and etc. Accessibility, traditional therapy is more accessible. Now ketamine is becoming more accessible as well, but it's, if we talk about insurance and all those stuff, it's a little bit different in terms of accessibility, and ketamine is a little bit more expensive than traditional therapy. Any questions so far? Let me see. No, I think we're good. And next one,
while you do that, let me jump in.
Jump in. The next one is something that I think would be good for you to answer as well.
So, ketamine has got a really bad rap from the past. I mean, it has been an anesthetic drug that has been approved. It's still used actually for trauma and pediatric from the 60s. If you Google ketamine today, the first thing that would come up would be horse tranquilizer. And it's used in the vet industry because of that exact thing, because it doesn't drop your blood pressure, it doesn't drop your breathing rate, it doesn't drop your vital stats. All of them stay stable. So you could dart an animal. I'm just going to go with the vet version of things right now. You could dart an animal, it will put it to sleep, sedate it, will not drop its blood pressure, will not drop its breathing rate, will not drop its pulse. So the vitals remain stable, and its half-life is 17 minutes. So you dart the animal, whatever you need to do, you've got 20 minutes to decide, do you need to redose or run is the option to that. That's how consistent that medication is. Now, on the side note, it has shown in microdosing values, in 1/10 of that dose, a slow infusion given over 40 to 50 minutes has helped with treatment-resistant depression, anxiety, PTSD, and on top of the chronic mental diseases, it has really shown help with chronic pain, chronic fatigue, CRPS1, CRPS2. It has really shown a lot of difference on the microdosing value on chronic mental illness and chronic pain, just to divide it. We as physicians, and I will take the responsibility on top of every other physician, that we have always treated pain and mental illness as an acute crisis. When it becomes a long-term thing, we have to switch gears to a chronic disorder, which we don't. We continue to treat pain as an acute issue, mental disease as an acute issue. We've never changed gears to going down to a chronic format of treating a chronic disease. So yeah, we can treat the flares, we can treat the acute components, but you do have to treat the underlying disorder, chronic pain or chronic mental disease, under chronic prevalences. So we as physicians are partly responsible for not treating the chronic and just treating the acute portion of it. Hence, we have to change gears to get away from opioids, from benzodiazepines, from trazodone, from Xanax, from every other drug you can imagine, to rewire the brain. So the word you want to look for when you Google ketamine is not horse tranquilizer, is neuroplasticity, because the receptors it uses, no other drug uses. There are glutamate-based receptors, as Ari was saying, and NMDA receptors. No other drug uses that. Maybe a high-dose magnesium might touch it. But mostly, ketamine is the only drug that uses a set of backup receptors that work on the brain. So the idea is to promote the use of these backup receptors to a mainframe receptors, to get them upgraded, turning a 3-lane freeway into a 4-lane freeway. That's the general gist of it. Sorry, us in LA would know what freeway traffic is. Even the Bay Area know that too, so I'm going to take the freeway thing away.
4-way? I don't know what you're talking about, but I really like it. I also want us to kind of mention the elephant in the room. There's a lot of misconception about ketamine, and we see it in the news today. And one of them is the tragic death of Matthew Perry. And it immediately puts people as association to ketamine. That was the reason. And I want you to kind of talk about a little bit about the option for overdose and what can lead to misuse of that, and especially in the light of that horrible tragedy, and what it means for ketamine use.
I totally agree. Thank you for that. It is total tragedy, especially down here in LA. He was a homegrown boy next door. It's a big deal. Everybody's very saddened about it. Um, I would like to, just for clarification purposes, he had 4 other drugs in his system other than ketamine. He had Percocet, OxyContin, benzodiazepine, and ketamine. So, and getting into the hot tub with all that doesn't help. But I will say, out of all the drugs in the system, it is the most hemodynamic, stable drug to use. Given all of that, it is not to be used unsupervised. You do need a therapist or a doc or a nurse or somebody. It's not a home use drug. And I'm going to take it back to, we've lived this life before with the Michael Jackson propofol drug use. It is also an anesthetic drug. It is not for home use. Similarly, ketamine is not for home use alone. You could use it at home, but it's not an unsupervised drug to use. Very effective. It does the job what it does, but it's not a unsupervised drug to use. So I will say one of the things that got him into trouble, more than trouble, is the unsupervised version of it. Getting into a hot tub doesn't help either. But as effective as that drug is, as hemodynamically stable as the drug is, it is a psychedelic. It is a hallucinogenic. It does belong to a family where you could have dissociative an experience. All of those who've used ayahuasca is the closest experience you can get to it, except ayahuasca is a 6-hour run.
7 to 8 and 7 to 8.
I was being nice. I was being nice here.
But it's a some people call it mini ayahuasca. Some people call it that, in terms of the deepest of their experiences, the detachment from the body, you are correct. Mm-hmm.
So, it does, drug by itself is very safe, but in the wrong situation, in the wrong circumstances, setting, it is not, the abuse potential and the disaster potential is sky high. It cannot be mixed with other drugs. It cannot mix with alcohol. It cannot be mixed with other stimulants. There's a lot of, if you're really anxious and you have 3 monster drugs, 3 monster drinks before it, it's not ideal to have that. So it really needs setting. You need somebody like Adi next to you to actually guide you through this process, to have really a therapeutic effect. If you really want the therapy portion out of it,
yep,
it needs supervision and guidance.
There are two, basically, I think it's important to explain, there are two major approach to ketamine treatment, right? One, the medical approach, and one, the therapeutic approach. Both, are effective, and you have me and Deep here. We are collaborating and doing both at times. So, the medical approach is more of a passive receiver of the medicine, the chemical boost for the mood, and you get the medicine and you leave it, whether you have your own therapy afterwards and all that. And the therapeutic approach is a combination of a medicine and a preparation session and an integration session, which is extremely important. And it's also what elicits the long-term positive impact of that, right? You look at the ketamine session as part of a longitudinal plan of how to get yourself better, right? So it's a more guided experience. Both are the main approaches to ketamine. We all are doing all of it, so we can attest to it. But there is also different. It gets us, I think, to the different modalities, right? How there are different ways of receiving ketamine, right? And Deep is working a lot with IVs, and there are, I think, Deep, you would be able to attest, there's pros and cons to it, right? It's I think the pros is really fast acting, and you have the ability, and we talked about the benefits of it, to fine tune it, right? So because it's an IV, then you can do the precise dosage in the moment, which I think is great. It is invasive, and you have to be under medical supervision, right? Versus the IM and oral administration, which a healthcare provider, which is also someone like me, can be in the room to supervise. You can less fine-tune it, but it's still fast-acting. The IM is fast-acting. IM it's like a shot, intramuscular. Like
intramuscular.
Like when you get like the flu shot, right? It's also fast-acting. You have less ability to control the dosage because it goes in. And it also has a fast-acting effect. And the oral is more slower because it's more of an observation. It's going to dissolve under your tongue. It's more of an observation of the absorbing it through your mouth. And it's also acting after 10 to 20 minutes. All of them are short-lived experience, an hour and a half to 2 hours. And Deep, jump in and correct me if I'm wrong. There's also
You're doing great.
There's also the nasal spray, which I don't use in my practice, and I don't know, Deep, if you're using it, but that's it's more self-administer, and I think it's more used for panic attacks and immediate and anxiety relief. It's also FDA approved though.
So, if I can interject, the theme song is, if we could put ketamine in a pill and have it like any other medication you could, it would be done. The trouble is the acid component in the stomach destroys the ketamine molecule. So the theme song of all of this is bypassing the gut. IV bypasses the gut, the sublingual absorbs it under the tongue, the nasal absorbs it behind the nose, the IM puts it in the muscle. All of those different routes are basically to bypass that gut acid level, because that'll break down the molecule. And hence there's a quick onset. The IV is quick, it's controllable, it's upgradable, it's downgradable, it's faster, slower, clutch, brake, steering wheel, whatever you want to call it. The IM is less, the sublingual once you put it in, but all of them have their own onset times and delay times, lag times. But gold standard, I would say IV is the best because it bypasses the gut, it bypasses the liver, and you have full control of how much milligrams you're giving and how fast you're giving the milligrams. Two big variables to control that advent. Heavy lifting, when you want to do the treatment-resistant depression, chronic pain stuff, anxiety, it works really well to do an IV. For maintenance purposes, the other routes work well. Again, different choices, different component of it, but it works with that intent. Logistics of some are easier, logistics of some are harder, so it makes a difference of that. But at no given time, I would say you want to be unsupervised because you need somebody around to keep an eye on you.
And what we do is, we're there throughout the duration of under the medicine. So this is how it should be, right? And I think this is how it leads to misuse if it doesn't happen. Deep, can you talk a little bit more about the mechanism in the brain of how it alleviates the symptoms for depression, PTSD, chronic pain? Like, give a few sentences about that can give more clarity.
Absolutely. So, the whole, if you think about it, the brain's like a big motherboard for a computer. Anytime you have a glitch on an electrical circuit, the easiest way on your iPhone or your Android, Samsung, the easiest way to fix any glitch is to reboot, switch it off and turn it and reboot it on. Now, the brain's reboot it never actually switches off. It switches off only one time when you're done. Even while you're sleeping, the auditory system is still working. So you never actually shut down the brain. Systems are always working. They might go down to bare minimum, but they're always working. So rebooting the brain is a rare, non-occurring commodity. But if you can get a spare set of receptors where you can park this electrical activity, you can actually get the closest to reboot. And that's what you're going for. The whole ketamine therapy, all of this is based, actually all of them, MDMA, psilocybin, ketamine is all based on if we can park all of the electrical activity off the mainframe for a little while to get as close to reboot is what you're going for. The mainframe consists of 3 receptors right now, actually forever. Opioid, serotonin, and dopamine. Those are the big 3 receptors that the brain uses as a mainframe. Hence, all of big pharma's medications are based on opioid, serotonin, and dopamine. So if we can get a fourth receptor in there, a fifth receptor in there, a fourth lane on the freeway or a fifth lane on the freeway, it'll help the neuronic activity to pass a lot easier, hence getting depression, which is an understimulated area, to be passing neuronal activity a lot higher, or anxiety, which is a hyperactivating, to calm down a little bit, whichever way you want to consider that. Hence, TMS, which is the electrical way of getting to the brain, is how the magnetic way of getting to the brain, or ECT, which is the electrical way of getting to the brain. So I'm going to digress here, but those are the three ways you can get to the brain: chemically, magnetically, or electrically. Before I digress anymore.
That's awesome. And you know, ECT used to consider like also a treatment that doing that reboot that you talked about, but highly invasive. So that's, you know, that was one of the cons of that treatment as well. I wanna
ECT is not benign. You know, there's a lot of cognitive loss, learning loss, and
short-term
memory loss in that.
I actually used to work with ECT clients, used to be present during their treatments. So it's almost like in the movies where you like.
It's archaic. It's an archaic old school formula. We should
totally old
actually.
school. It works for a lot of people, but it's very invasive. There's a different way. That's what I love about ketamine. It's invasive, but less invasive, right? You know, it's and it can actually, you know, get to that reboot without going to a hospital and actually going under, you know, and a surgery almost. It's almost like a surgery doing ECT. It's the same conditions, according to what I know. So the last myth about ketamine that we want to discuss some of them. I'll name a few, and then you can name the stuff that you think are interesting. I know that I hear sometimes that ketamine therapy is one size fits all. Like, you know, you take whatever and you for everyone. And I want to dispute that. I think it's very customized treatment. And me and Deep have a lot of conversation about each and every client, their medical condition, psychological condition, what kind of dosage is a good fit for them. It has so many things that are kind of depends on it and on the specific client. And, you know, we do the matching according to each specific client. We actually talk about it a lot. So I want to dispute that and kind of say that the therapeutic effect and how clients come into that really depends on the dosage that we, you know, decide. So that's one of the myths I wanted to discuss. And also, and again, write questions or all kind of stuff that you want to answer. I'm monitoring the chat.
I'm going to jump in on that really quickly. So, you know, the recommended doses, and like Ali said, it's not one size fits all. It's two-part components. One is 0.4 to 0.6 mics per kg body weight. That's just by your body weight status. Now, you all have a different metabolic rate. If you think about alcohol, because it's all easier for us to think about that, some people metabolize alcohol a lot faster, some a lot slower. So depending on the meds you're on and how fast you metabolize a certain drug is what determines what your dosage would be. So she's totally right into it has to be customized to a particular patient, not only to their weight, but to their metabolic rate of a drug metabolism. So you have to take both variables in. I'm not going to count age and how long you've had the disorder and how many meds you're on and all the other XYZ, but it's truly the top two that determine it is your kg body weight and your drug metabolism rate, just to begin with. And there's a slew of other issues that determine how much is your ketamine dose for an individual patient. So yes, truly customizable.
True. And also psychological readiness, right? And we talked about it.
Yes.
Like a person that never used any psychedelic medicines in the past comes with great anxiety or about the use, and also have some control, not issues, but some issues with control. You know, we have to consider that because we don't want it to be, you know, we want the person to come in a certain state of mind to this therapeutic process. And it's also, you know, so we consider the medical aspect, the psychological aspect, and past experiences as well, along with everything that Deep just said. So it must be considered, and not just, you know, give people whatever
one size fits all doesn't work in any case.
In any case. And another thing is that a lot of people are, I hear from a lot of people that ketamine only works like short term, and you always have to do it if you wanna feel better or like alleviate symptoms or kind of promote positive outcome. And while ketamine does have the immediate effect of reducing symptoms, and sometimes you have to repeat it and do like booster sessions, if you look at it as like a therapeutic plan, and you take care of yourself between sessions, and you journal and you meditate and you do the mindfulness work and you go to therapy, then that's not the case, right? So it really depends on how you view. Am I coming to do ketamine treatment to get the dissociative feeling? Then yes, it's probably going to only impact you for a few hours or days or weeks, but or a week. But if you have the ability to look at it as a neuroplasticity process, and now I have the brain ability to kind of reorganize it, I have the ability to nurture the brain and nurture my mental health, then it's really can be a longitudinal impact and deep jump in and give your 2 cents of it. But that's how I see it, and that's how I see in people and the improvement and progress.
I got 1 cent, not 2. I just got 1. The drug can do what the drug can do. It can do maximum 50-60% of the work. You have to do the remaining 40-50% of the work. The journaling, the actually in dive of what do you actually want as a goal, the navigating is all going to come from you. So it does take the whole village between the therapist, your therapist, the ketamine provider, yourself, the journaling, all of it to come together to actually move the needle.
That was a good sense, though. I agree. I completely agree. It needs to be looked at as a treatment protocol, right? Like part of many things that we need to do to take care of ourselves. So it's work. We do a lot of work to take care of ourselves. Part of it is it. I want to talk a little bit about safety protocols from your perspective. Like, how do you see it? Like a safety protocol in ketamine treatment, and how do you do that in your practice?
So, I will say it is an anesthetic. So most anesthetic gases or IV have a side effect of nausea. If anybody's gone through a surgical procedure, you wake up, as best as we try, with a little nausea. So it does have nausea as a side effect. We do give it an antidote of Zofran, ondansetron in the IV, but you can give it otherwise in oral pills. They come in sublingual too, to negate that. It is a side effect to have. The dissociativeness, and most importantly, the depth perception. Your foot to floor ratio is almost off for an hour after that. So driving or climbing stairs or coming downstairs is really tricky. So I always advise all of our patients, take the elevator, don't drive, because your depth perception's off for almost an hour after that, because you're getting these new receptors into a system that have not been used to all of this. Those
also,
are my 2
light.
biggest.
A lot of clients are complaining about like light sensitivity at the beginning when they're coming out of the treatment, and the room looks different. So definitely this depth perception is
not only light, actually all your sensory input, tactile, auditory, hearing, visual, all your sensitivity, because it's a new set of receptors, your threshold sensitivity is a lot higher. You hear stuff a lot more clearly. You see the light a lot more brighter. You hear, everything, your sensations to touch is a lot more. If you're going to have a sip of water, you'll feel it go down all the way through.
And the music.
And the music.
It's audio distortion that actually are very pleasant during ketamine, that you feel the music within you, like all this like auditory perception is very, it's actually very beneficial during that under the influence. But yeah, you're right. Let me see if there are any questions. I'm trying to monitor the chat. No questions yet. In terms of, and I talked about it a little bit earlier, is ketamine for everyone? So no. there are certain individuals, whether there are medical condition or psychological condition, that should avoid due to potential risks. From the psychological perspective, people who have psychosis or schizophrenia, or certain substance use disorder are not recommended to do ketamine. From the medical perspective, and Deep can talk about it a little bit more, people who has like high blood pressure, uncontrolled high blood pressure, or cardiovascular condition, or severe liver disease, those are also, and certain neurological condition, those are also people that should avoid using ketamine. Also, pregnancy and breastfeeding are also not conditions, but not recommended to use ketamine. Conditions. I was pregnant. I can say condition. It is a condition. It leads to a good outcome, but it is a condition.
I'm glad I stayed away from that one. Thank you.
You did good.
But I will say, there are some obvious contraindications that, it's common sense at that point. Pregnancy, as she said, is one. Schizophrenia is an absolute contraindication. A manic episode in a bipolar patient, active manic, is an absolute contraindication. I will say there are relative contraindication. Cannabis use, we try to tell our patients if they could halt their cannabis use at least for 2 weeks before we start treatments, just because the THC is a high and ketamine is a high. They both get into the same zip code. Getting us a double high is not really what we want to do. So if you're trying to replace one addiction over another addiction, is really not the way to go for it. So the relative contraindication would be not using cannabis, THC especially. If you're using cannabis, which is low on THC, high on CBD for sleep, we can let that go, because the goal for that is just getting sleep. And yes, we are big proponents of sleep. Not great on having a manic episode to do ketamine at the same time. High anxiety levels, high caffeinated levels, a monster Red Bull drinks, truly to be avoided. And because it's an anesthetic, it does have a little bit of reflux in it. So we try to keep an NPO, nothing per orally, have an empty stomach at least 2 to 4 hours before it. You can have some liquids, but not like a whole steak meal or breakfast before you do the drug. So you want to make sure, because it is an anesthetic, you want the NPO 2 to 4 hours before and the nausea afterwards. But mainly the depth perception afterwards is the biggest issue, and to make sure you don't make any big decisions in that window.
And I always tell my clients, take it easy that day, right? You need to control what you're consuming, even like news or all kinds of stuff. It's a very raw state, right? Emotionally and physically, right? So you have to make good decisions for yourself that day and take that easy. There's a lot of slowness after, even if the medicine is out, there's a lot of slowness that is pleasant. You slow down. And I'm a very fast person, so I can tell you that. It's there is a slowness to it that is very pleasant, that you should take that easy, right? You should take that day easy. Again, some people go back to work, they can, but what I tell my clients, the recommendation is to take the day easy, to kind of consume positive things. We have the opportunity to change our brain chemistry, which is pretty great. The neuroplasticity actually lasts after for a few days, but that day is a day to really take care of yourself and consume positive rest, like thinking, like creativity, all kinds of stuff that we really need to look at it as an opportunity. But no driving. There is, I'm wondering what you think about integration. From my perspective, there are 2 ways to integrate. Some people come out of ketamine treatment and immediately want to talk, which is not a bad thing, but it's a different kind of processing, right? So it's an integration that happens immediately after. The recommendation is also do an integration a few days after. So always provide that as well. And it's extremely beneficial. There, under the medicine, and I don't know if, people that are here know that can be some talking. It's very different from person to person, but the majority of people do not talk. They can show some emotions, but your body's very calm. I think this is part of the relaxation aspect of ketamine that is extremely positive. It calms your body. It calms your body. You feel like, almost like floating and heavy on the same time, right? That's I think, I don't know how to describe it, but it's just like, that's what people describe when they're coming out of it. It's kind of like heavy and floaty at the same time. It can be a dreamlike experience. The experience can be different for people. It can make sense and it cannot make sense. It can be very visual. It can be very emotional. Depends on the person, then what they're setting before, the intention they're setting before as well, if they do. But no, like I always say to my clients, no bad trips, right? You go through what you need to go through. So that's part of it.
To add on to your thing, it's the subconscious mind and the conscious mind are constantly at a seesaw battle. Conscious mind's job is to keep you functional on a day-to-day. As there's sensory input data coming in, we have a lot of it nowadays. It's a lot coming in. It is in constant triage mode. This is important. I deal with it now. This is trash. I'll deal with this later. Now, trash later. Now, trash later. Literally, the brain is running in this mode every second of the day. That's how much sensory input we get. That later stuff sits in the subconscious mind, and we never actually get to it. The trash is easy, and the now is easy. That subconscious mind gets loaded at the end of the day, at the end of the month, at the end of the year. It is fully loaded. And a lot of our grassroots anxiety, depression, PTSD stems from that subconscious mind. But the conscious mind job is so good to keep you functional day to day that it keeps that subconscious mind at bay. One of the ketamine's job is to drop that guard where you can access your subconscious mind, clean up that closet, drawer, and that mess that has been sitting there and just brewing and creating a mess, creating that anxiety, creating that depression, creating that OCD. Everything stems from something living in your subconscious mind. And the conscious mind will not let you access it. So if you can get in there, access it, clean it up, you might actually get rid of each one of them separately.
And I want to piggyback on that because it's very important. It's not that traditional therapy doesn't work. It does. I view ketamine as treatment enhancer. It brings you to where you need to get to faster. Because it takes that kind of main frontal lobe door down and have the pathway to where you need to get to. It serves as a treatment enhancer, and that's big. Because people feel stuck, and traditional treatment has its limitation. I've been a therapist for more than 15 years. It has its limitation. I will admit that. We're not, as therapists, we have limitation to get to where the client needs to get to. This helps the client feel less frustrated, less stuck for the clients that are a good fit and eligible. It promotes them in the self-exploration path. And it starts with the preparation, because when someone is going under the medicine, they already think about what can come up. So the therapy starts there. This is how I view it, right? And then they go under the medicine and their defenses are down, and they're actually willing to deal with what is going on. So for some people, it can serve as a huge treatment enhancer, and speed up the process in years. Sometimes I hear people say this was like 5 years of therapy. And I hear people say that. And I think that combination of therapy and all kinds of other modalities, it doesn't have to be psychological therapy, but combining ketamine with other modes of treatment and really treating it as a treatment plan is something that is super beneficial. I'm a big believer in this medicine, I must say. And I love doing this work. I think that will...
I will say, one of my patients' best line, it's not my line, and I'll give him credit for it. It's like being in therapy with yourself.
Mm-hmm. I really like
all
that.
Your secrets are known.
You can't lie to yourself. It's like you can't. It's just, it confronts you with what you need to be confronted with. Our most human basic stuff kind of go through the frontal lobe. That's what I say. Bye-bye frontal lobe. Only messes up with our life sometimes. It's like we build a Tesla on a very old car and we kind of forgot about it, right? So That's how I sometimes see it. I want to ask a juicy question that I was asked, and I'll ask it because we want to confront with all those questions. Is ketamine addictive, Deep? What are your thoughts around that line? From my knowledge, I can say one line about it. I know there is a psychological sometimes addiction to it, but not a medical addiction. And you can correct me if I'm wrong.
Oh, no, no. It's not because, first of all, it's a really short acting drug. It's most of the addiction component comes from our long acting drug. Um, just for variance purposes, you need a psychedelic drug to have at least one concert length effect. You're not going to go redose in the middle of the concert, just to let you
One
know.
concert. I love that. I'm going to use it.
Right? So, half life of ketamine is 17 minutes. You're not even going to make it through a concert. You'll have to go redose really quickly. So it didn't in the 60s and 70s. Did have an upheaval where it would be a good recreational drug, but because it is so short acting, it didn't actually make it. So all ketamine street use today and even in the past needs a mixer. Something has to be added to it to increase the time of it so that it has that effect, the one concert length effect. At 17 minutes, it's really too short by itself. So it never actually got caught on, and hence it's not that addictive because it's just too short acting. For its own benefit or non-benefit, it's too short acting to be addictive.
Yep. That was what I'm familiar with. In terms of, I also want to point that out. We won't go enough into it because we didn't give people to ask questions, and I want to do that. I want to do a Q&A, short Q&A. But I'll just go over the ethical considerations that we have, something that we may want to explore in future webinars. But, every client needs to know and understand informed consent for ketamine. And we really stress that. Deep is stressing it in his practice, and I stress it. People needs to know what they're coming into, really get all the information they need to have potential benefit, risks, and all that before they're going in. This is crucial, and I'm stressing it in my practice, and I know Deep is as well. So that's one aspect. Safety and monitoring, like Deep said, don't do ketamine alone, right? It needs to be monitored. It's part of therapy. It's we know what we're doing, right? And that's why it's very important to also go to people that are trained. There's a lot of stuff out there, and really choose your provider, right? I always tell my client as well, go shop around, check for people, look for their credentials. This is highly important. People with credentials and that are involved in this are out there. It's there. Anything else, Deep, that I think, again, we talked about the potential misuse of it and recreational use, like I said, the quality of care, and there are research gaps, and I think these research gaps are actually being filled out because people understand the benefit of ketamine treatment and of other psychedelic as well. So there's a lot of boost in research in the past few years, and I think it will continue. We'll have more good results around that. Anything you want to add before we're opening to short 9-minute questions?
I'll just one last thing. There most medication, most pills, SSRI, SNRI, benzos, whichever way you look at it, the meds do the work. The pill do the work. You have to be on it almost lifetime unless you taper off it. The goal for this medication is actually very different. You want the brain to do the work. You want the brain to do the neuroplasticity work. So think of it as a spark, just the initial treatment. That's what gets it done. And the brain picks up the wildfire. And from there onwards, the brain does the work. So it's not like something like ketamine, you have to be on it for lifelong, as opposed to the meds that you take. So very different format, very different way of approaching it. And you do the initial 6 infusions. You might need a couple of boosters down the road, but that should be about it. It's not like something you have to do lifelong, as opposed to all the pills.
Yep. I'm opening to question, and we have 8 minutes, and I didn't leave enough time for questions, but
Don't worry.
I think we answered a lot of it, but any questions? from the audience? If not, that's good. It means, in my eyes, if there's no Q&A, it means we answer all the questions that people had. And we touch all the topics that are super important, which is good. And we also recorded it so people can... Jessica, I see you coming up. Do you have any question?
Yeah, so I work for Journey Clinical, and a lot of my clients are doing the first two initial rapid dissolving tablet sessions with me. And they can dose anywhere from 200 to 400, depending on the person and psychedelic experiences, yada, yada, yada. I'd be curious to know both of your opinions about, they do the 2 sublingual tablet sessions with me, and then they don't return for more. And I'm wondering if for some people just 2 sessions is enough, or is it more advantageous for them to do, 6 to 8 complete sessions? Like you're saying, medicine can do 50% of the work, you have to do the other 50%. I'm wondering if the more sessions they have, then I don't know. I just wanted to know, like, if it's more beneficial for them to do more of the rapid dissolving tablets, or if there's any difference between IM and IV and that. I know that's probably a hard question.
Deep, I'll let you
There's
answer.
a lot of there's a lot of questions in there, but yeah, I'll take that. Now, I would say they would need more. Just a real short answer to that. Yes, 2 would not be more. You want to get 2. 1 is getting used to it. 2 is you want to get directive, and then 3, 4 is where you really make the difference. So if they can keep going, I'd say 6 would be the goldenish number, give or take a few, but 2 is a little under, if you ask me. That's just getting used to it. You have to do the work, but you got to do 4 and 5 after the work to get more out of it, to get the therapy work out of it. 1 and 2 are almost like recreational.
In my practice, I recommend 4 to 6. It also depends on the presentation that the client is showing up with. But again, me and Deep talked about it. 1 is like an intro to, it's really like you really understand where your body's going. You get the initial anxiety out of the way of like, oh my God, what will it do to me? So there need to be some continuation to it. And my recommendation to my clients is 4 to 6 sessions.
One is the preview for the movie.
Exactly.
You gotta watch the movie.
What we say. Yeah.
I like that.
I know your other question was what's better, sublingual, IM, IV. I think that was the other half of it. I'm a big proponent of IV because you get full control of dose and rate, and you can actually really tailor it to the patient. But it has a lot of logistical issues because you need a nurse who can get the IV in and blah, blah, blah. The sublingual and the IM are a lot easier to do. Again, sublingual is totally easier to do, but it does have a lot of wash off as you get into the higher doses. Once you get above 400, the actual absorption bioavailability of 400 milligrams of ketamine to what is in the bloodstream is under 50%. So as you get into higher doses, you're not getting as much into the bloodstream versus in the IV, IM, you can do a lot more higher doses and get it into the bloodstream. So
the more higher you go, the less observation, the less
in the sublingual, yes.
Can you say that again? I didn't hear you. The last.
So as you get higher doses in the sublingual, there's lesser bioavailability in the blood. Because think about it, if you put it under your tongue for absorption, it will only absorb what blood circulation allows before saliva gets in. And the saliva, you have a choice of do you spit it out or you swallow it, which is a waste. So if you're going up to 600 milligrams of ketamine sublingual, it's almost equivalent of 300 milligrams because almost half of it got wasted. So if you're in higher doses, I would shift to IM or IV. If you're 200 and under, sublingual work will do the job.
There is a limit to the absorption.
The option on that.
Time.
The washout trades
Yeah,
off after
in terms
that.
of time, right? You can't have someone holding their saliva for like an hour, right? Like it's 15 minutes and there's a, it's also, you know, a limit to how much. So higher dosage, the recommendation, like you said, is IM.
I'd say under 200 is a good sublingual dose. Anytime you cross that, you want to switch routes.
Anyone has more questions, we will also send an email, and you can always like send us more questions, or if you want to contact us, we will be happy to answer more questions. We do plan to do like more webinars, because I know there's, you know, we really want to have the, you know, people well educated around psychedelic medicine and how beneficial it is. So deep, amazing information. I learned something today, which is awesome. Like I always learn from you. You're such a good like colleague and mentor.
You know, there's a lot of myth. There's, you know, ketamine and the entire psychedelic world has a bad rap because big pharma does a lot of work dumping on them. But the drugs, ketamine, MDMA, and psilocybin all have really good results. Phase 2 trials have shown that they do a really good proponent on results. It's just not, it's plant-based, so big pharma doesn't like them.
Yep.
Want to get in trouble for that.
Hopefully we will, you know, show good results in research and manage to overcome it, because it really does so much good to people. And I see it in my practice, and it's such an amazing work to do and to see how people react to it. It's, you know, it's like he said, like it's all about the bad rep. So we need to help people see the truth around that, and with a lot of information and research and all that. Let us know if you
Forest from the trees. Forest from the trees. You got to differentiate the good from the bad. Don't get stuck in the weeds.
Yes.
I'm happy to take, if you have any questions at any time, just let Adi know, or give her a call, give her an email. Happy to answer anything.
Really nice doing that with you, Deep, as always. And thank you everyone for joining, and hopefully there was some good information for you, and we'll send a recording afterwards so you can send it to people that may be interested. Thank you so much, everyone. Really nice
Thank
meeting
you guys. Thank you.
Bye.
Thank you.
Bye.
Bye.